Hello everyone, I will tell the story of how I switched from inside out to outside in technique in transforaminal endoscopic discectomy. This transition is quite recent. I have no financial interest or relationships to disclose. This is my hospital in İzmir. After I decided to learn transforaminal endoscopic discectomy, one of the most challenging issues for me was what the terms inside out and outside meant. Now I know. Let's say we are going to perform a left L4, L5 discectomy. Let's draw a line connecting the lower posterior corner of the L4 corpus and the upper posterior corner of the L5 corpus on the lateral fluoroscopy image. Our guide wire will reach this line in both inside out and outside techniques. However, we need to think three-dimensionally. While the guide wire is here in the lateral image, where will it be in the AP image? This is what is important. Now, let's draw a line passing through the medial faces of the left pedicles of L4 and L5 on the AP fluoroscopy image. Then let's draw a line passing through the tips of the spinous processes of L4 and L5. While the guide wire is on the line connecting the medial parts of the pedicles in the inside-out technique, it reaches the line connecting the spinous processes in the outside-in technique. In addition to the line connecting to medial edges of the L4 and L5 left pedicles, let us also draw the line connecting the lateral edges of the same pedicles. In inside-out technique, the ideal point for intracanal disc herniation is the line connecting the medial edge of the pedicle. However, if the guide wire is at the posterior edge of the corpus in the lateral view, and somewhere between these two lines in the AP view, our technique is still valid. In other words, it is still an inside-out technique. It should not be further laterally than this lateral line. If it is, it could damage the root coming from above the exiting nerve root. In this case, the left L4 nerve root. Let's say these are the left L4, L5, and S1 pedicles. We have taken all the bone structures. We are talking about the L4, L5 disc. Let's first draw the medial pedicular line, then the lateral pedicular line on both the AP scope and our drawing. Here, the area where the needle enters the disc is this area colored green. That is the interpedicular area, interpedicular zone. In the inside-out technique, although the needle usually touches the bone first, it is then slid from the bone, brought into contact with the disc, and inserted into the disc. In the outside-in technique, the needle makes contact with the L5 superior articular process and never enters the disc. To understand the inside-out technique, we can look at the needle position in these CT images. This is not an endoscopy case. It is a preganglionic transforaminal epidural steroid injection case. However, the needle position is almost the same. On the left, in the lateral scout image, we see it reach the level of the posterior corners of the corpus. In the axial image on the right, we see it is under the L5 superior articular process and contacts the disc. When we look at the history of transforaminal endoscopic discectomy, we see that it is two separate components: open posterior lumbar endoscopy and percutaneous lumbar posterolateral approach, developed independently of each other. And then percutaneous posterolateral endoscopy was born from their marriage. Percutaneous posterolateral endoscopy has evolved into transforaminal endoscopy, which in turn has evolved into inside-out transforaminal endoscopy, When inside-out transforaminal endoscopy could not solve all the problems, Thomas Hoagland developed the outside-in endoscopy technique and published in 2003. Let's take a look at the publications that define these stages. The percutaneous use of the endoscope via the lateral route was first published in 1986. The disc was entered bilaterally. While the disc remover was working on one side, the surgeon was looking at it with an endoscope on the other side. The inside of the vertebral disc, not the neural tissues, were imaged. Still, it was an important step. To my knowledge, Parviz Kamil explains and draws the Kamil triangle clearly for the first time in this book in 1991. The era of transforaminal endoscopic discectomy was now beginning. The safe zone described by Kamil. Even if you look at it laterally or from the AP, it's a triangle. However, what Kamil means is the triangle in the oblique view. The upper end plate of the caudal vertebra forms the caudal edge of this triangle. The superior articular process of the caudal vertebra forms the vertical edge. The exiting nerve root forms the hypotenuse. He used the endoscope intermittently through the working cannula. So he puts a disc remover and then he puts an endoscope. The endoscope has saline inflow and outflow. For the first time, the endoscopic photograph of a neural tissue was printed in this book, Exiting Nerve Root. Young published the original inside-out technique in 1999. In Young's technique, instruments could be used through the endoscope, which allowed saline inflow and outflow for continuous irrigation. The era of inside-out transforaminal endoscopy had begun. In this article, Young published for the first time a photograph of a neural tissue inside the spinal canal, the traversing nerve root. In 2003, Dr. Thomas Hoagland published the outside-in technique as a sole author. Here, Hoagland wrote that he designed special reamers in 1994 and that he operated on more than 1,500 disc patients since 1999. Let me remind you that Hoagland was a co-founder in the establishment of Joymax in 2001. In the lateral radiograph, the tip of the 2 mm diameter curved guide rod is seen at the posterior edge of the S1 corpus, while in the AP radiograph, it is seen to reach the midline. Hoagland was performing foraminectomy with reamers sent over the dilators. The patient is in the lateral decubitus position. What I find strange about this article is that Hoagland reached the midline, then removes the endoscope and blindly uses the disc remover through the working cannula. In 2004, Hoagland separated from JMax and in 2006 founded his own company, Maxmore Hoagland Spine Products. Meanwhile, the inside-out modified technique called the half and half technique was published by Lee et al. Using the YES system in 2007. The window of the beveled working sheet is approached across the disc space so that the epidural space and the annulus and PLL are visible together in the endoscopic view. On the left, you see the half and half technique on the cadaver. Half of the working cannula is inside the disc, and the other half is in the foramen, viewing the spinal epidural space from the lateral side. The picture on the right shows the image taken with the endoscope using the half and half technique. F, epidural fat tissue, P, posterior longinal ligament, and D. Herniated disc stained by indigo carmine. Joymax is still among the most widely used endoscope systems in the world. This system uses the trephines that Hoagland first designed. The hand drills that Hoagland later developed for Maxmore were first shown in a German book chapter published in 2009. In the image in this publication, the guide wire was advancing towards the midline, but the hand drills was not passing the medial edge of the pedicle. The first publication showing the hand drill advance to the midline was published in 2021. In the image in this publication, the increasingly thick hand drills reached the midline in the AP view. At this time, in the lateral view, the tip of the drill was at the posterior superior corner of the caudal vertebra. The scope we use for inside-out and outside-in techniques is the same, transforaminal scope. The brand of the scope we use is Maxmore. There are two irrigation channels. Saline is given from one at the same time and flows out from the other. Saline also flows through the working channel. We initially applied the inside-out technique with general anesthesia. Then we switched to sedation-supported local anesthesia. The approach was quite simple and comfortable for the patient. The patient lies flat on the fluoroscopy table in a prone position. We just put a silicone cushion under the ankles. The patient was constantly awake.
Sevgili Ömer, ağrın var mı?
Şöyle bir bakalım.
Ağrın olursa bize
Kafanı
söyle.
kaldır bakayım bir. Heh. Tamam. Çok güzel.
Ağrın olursa bize söyle.
First, we must obtain the real AP image in fluoroscopy. In other words, the end plates, cranial and caudal, to the disc level to be operated should be seen as a single line. The spinous processes will also be exactly in the midline. After obtaining this image, we drew the middle of the intervertebral disc space transversely. Then, the tips of the spinous processes, cranial and caudal, to the disc space operated are connected with a longitudinal line. The point where both lines intersect is the entry point of the needle. Then we draw the iliac crest as we feel it by palpation. The purpose of this is to move the needle entry point a little more cranially if the iliac crest passes cranially of our working trajectory. We use an 18 gauge, 15 centimeter long spinal needle for the first entry. After injecting local anesthetic into the skin and the subcutaneous tissues, we insert the spinal needle and push it towards the spine. We aim to ensure the needle tip hits the facet joint in lateral and AP images. The first bone, the needle contact, is the lateral surface of the superior articular process. We infiltrate 1 cc of Marcaine, the long-acting local anesthetic, into the superior articular process periosteum. Then we slit the tip of the needle to the anterior aspect of the superior articular process without losing close contact with the bone. To slide the needle, we pull it back 3 to 4 millimeters, turn its bevel dorsally, lift the head of the needle dorsally, and advance the needle. If the needle hits the bone again, we pull the needle back a little more and repeat the same process. When the needle touches the disc, we feel its rubbery hardness. We advance the needle under AP fluoroscopy control. The needle advances first through the rubber hardness of the annulus fibrosus. We advance the needle to the point where the resistance decreases. The point is where the nucleus pulposus begins. We ensure the needle is inside the disc by performing discography with half cc of contrast material. Then we send the guide wire into the disc through the outer cannula. In the AP fluoroscopy image, the tip of the guide wire will pass the spinous process, but not the opposite pedicle medial line. We remove the outer cannula of the spinal needle. Meanwhile, we make sure that the guide wire does not come off. We check the location of the guide wire again with fluoroscopy. We slide the thin dilator over the guide wire. While pushing the dilator, we make clockwise, counterclockwise rotations of 20 to 30 degrees. As seen in this picture, if the dilator does not slide smoothly over the guide wire may bend or even break. Or the guide wire may move out of the disc and damage vital structures. In this picture, the tip of the wire has advanced up to the lateral edge of the intervertebral disc. The rigid annulus fibrosus stopped the wire from further advancing in this case. We push the tip of the thin dilator up to the medial pedicle line or slightly behind it. Before sending the thick dilator over the thin dilator, we cut the facial tissues with the size 11 scalpel, leaning its back against the thin dilator. As dilator passes through the area close to the iliac crest, the fascia tissue becomes denser and tighter. Therefore, the scalpel should extend beyond the highest point of the iliac crest. The thick dilator is slid over the thin dilator. In general, advancement becomes difficult where passing close to the iliac crest. The thick dilator is advanced over the thin dilator to the pedicle zone. It does have to reach to pedicle medial line. Before sending the working cannula, we repeat the fascia relief process over the thick dilator with a size 11 scalpel. Initially, the bevel of the working cannula should point downwards. We confirm this by seeing the arrow on the handle pointing ventrally. The working cannula is sent over the thick dilator with its bevel facing ventrally. The working cannula's bevel should keep facing to ventral side until it touches the facet joint. To be precise, the superior articular process. The position of the tip of the working cannula is checked from time to time under fluoroscopy. When the tip of the working cannula touches the superior articular process, the cannula is rotated 180 degrees around its axis. Now, the bevel of the working cannula is positioned to face dorsally. The working cannula is pushed further and placed under the superior articular process. It is sufficient for the tip to be placed in the interpedicular zone. The distal ends of all instruments are inside the disc. The proximal ends are visible outside. All instruments inside the working cannula, namely the guide wire and two dilators, are removed. After checked on AP fluoroscopy, the working cannula tapped with a hammer to advance its tip to the medial pedicle line or slightly beyond. After the AP image, the lateral image is obtained and the half and half position is confirmed. Half of the tip of the working cannula is inside the disc and the other half is outside the disc, within the epidural space. For irrigation, we use isotonic saline available in 3-liter bags. We wrap the saline bag with a special pressure cuff, inflate the cuff to 30 mm Hg pressure and connect the saline to the scope. Then we place the scope into the working cannula. The way we hold the scope in the inside-out transforaminal discectomy. I rest my thumb on the proximal end of the scope and hyperextend the interphalangeal joint. I rest the instruments on my thumb while inserting them into the scope. This maneuver prevents tremor. We usually see the disc annulus after removing blood clots with the disc remover.
Tamam.
After perforating the annulus with the dissector, we insert the hook into the disc space. Our goal is to be sure that the traversing nerve root is decompressed at the end of the surgery. We check whether there is any compression on the anterior of the root with the hook. We mobilize loose disc fragments, if any. Then we remove the loose disc fragments from inside of the disc. Video of the lateral view, or almost lateral view, of the dura and the disc space. One of our cases. The dura of the traversing nerve root appears in white pearl color. It has veins on it. The yellow ligamentum flavum is just above it. Removing a big, beautiful free fragment is one of the most enjoyable moments of this surgery. We were happy with the inside-out technique, at least at the beginning. It was a very simple technique and we were getting results. So why did we switch from inside out to outside in? Because there were limitations. It was almost impossible to operate on L5-S1 disc herniations and caudally far-migrated disc herniations. There were also serious difficulties in midline disc herniations. Therefore, we started the outside-in technique, which has the potential to overcome all these difficulties. How do we do this? Let's say we are going to perform surgery for a right L4, L5 disc herniations. We palpate the spinous process and draw the midline. Then we draw a second line parallel to the midline, 10 to 12 centimeters to the right of the midline for the L4, L5 disc. This may vary depending on whether the patient is thin or thick. Fluoroscopy is not needed for these two lines. Then we draw an oblique line connecting these two parallel lines under fluoroscopy control. On a true AP view, this line should connect the tip of the right L5 superior articular process to the midpoint of the L5 superior end plate. Normally, the needle entry point is the intersection of the right lateral line and the oblique line. If I want to make an entry point more precise, I extend the oblique line a little more laterally. Then I take a lateral view using a metal rod. In the lateral view, the line of the rod should connect the tip of the L5 superior articular process and the L5 posterior superior corner. Once we obtain this image, we draw our line. Now we have a second entry point. This entry point is actually more accurate. It is custom made. During the surgery, we first touch the tip of the superior articular process with a spinal needle, advancing from cranial to caudal, lateral to medial, and dorsal to ventral. I remove the inner needle and inject Marcaine into the periosteum. Then we pass the guide wire through the spinal needle. When the guide wire touches the bone, we remove the outer cannula of the spinal needle. We first pass a thin dilator, then a thick dilator over the guide wire and perform the necessary dilatation in the trace. After removing the thin and thick dilators, we pass the outer cannula of the Tomshidi needle over the guide wire. When the Tomshidi needle touches the superior articular process, we remove the guide wire. We attach the pointed Tomshidi internal needle. We start to drive the Tomshidi needle into the bone by hammering it. When the tip of the Tomshidi needle starts to enter the superior articular process in the AP view, the tip should be in the middle of the superior articular process, not posterior to it in the lateral image. If we see it at the posterior edge of the superior articular process, there is a problem, which we will discuss later. After reaching the medial aspect of the L5 pedicle with the pointed Tomshidi needle, we replace the inner pointed needle with the blunt tipped needle and advance towards the midline in the AP view. At this very moment, in the lateral view, the Tomshidi needle should be in the posterior superior corner of the vertebral body. We remove the Tomshidi inner needle and send the guide wire. The guide wire should reach the midline in the AP image, and we should feel the bone, not the soft tissue, with palpation. We remove the Tomshidi outer cannula and send the hand drill over the guide wire. We turn the drill counterclockwise until the tip touches the bone to prevent damage to the muscles.
Evet, çekiyorum.
Okey, yeter. Kapat.
After feeling the bone, I turn the drill clockwise.
Çekiyorum.
Hı hı. Bu kadar yeter. Şimdi
Starting with a 4 mm drill, I continue with 6, 7, 8 mm drills. I should be at the posterior superior corner of the vertebral body in the lateral view when I reach the midline in AP view, which each and every drill, ideally. I use the 9 mm drill last. I remove the 9 mm drill and send the thin dilator, and working cannula over the guide wire, respectively. After the dilators and guide wire are removed, only the working cannula remains. The tip of the working cannula is posterior superior corner of the corpus in the lateral view, but has not reached the midline in the AP view. This is not the ideal position. If there was a midline disc herniation, I would have difficulty. However, the most important thing is that the tip of the working cannula is at the bone surface in the lateral view. This provides safety. I started the Ausat-in technique in the last 1.5 months and I have performed 11 surgeries so far. Even with such limited experience, I encountered problems. The biggest mistake I made in the cases was to insert the Tomshidi needle into the bone from the posterior rather than the lateral of the superior articular process. Look, in the lateral fluoroscopy image, the needle tip is posterior to the facet joint. I start hammering from here. Although I am almost medial to the pedicle on the AP radiograph, I am still very posterior on the lateral radiograph. This means entering the spinal canal early and from a very posterior angle. We are pushing the dura. Although hand drills do not damage the dura due to their spatial design, there is a possibility that I may cause a neurological deficit with compression. The working cannula is in the midline on the AP radiograph. However, it does not touch the bone on the lateral radiograph. In these cases, when you place the scope, the dura mater comes directly in front of you. Another case. When the pointed Tomshidi needle reaches the medial pedicle, it is still posterior to the facet joint on the lateral radiograph. Normally, when the tip of the blunt-tipped Jamshidi needle reaches the midline on the AP radiograph, it should also touch the posterior surface of the corpus on the lateral radiograph. However, here it is quite far back, that is posteriorly. The position error continues in all the following instruments. You can't fix it. Let's compare the cases where the needle was inserted correctly with the cases where it was inserted incorrectly. In the case below, when the Tomshidi needles start to enter the bone on the AP radiograph, it is somewhere between the dorsal and ventral edge of the superior articular process on the lateral radiograph. In contrast, in the case above, the Tomshidi needle has almost reached the medial border of the pedicle on the AP radiograph. However, it is still posterior to the facet joint on the lateral radiograph. Of course, the outside-in technique is not immune to guide wire problems, just like the inside-out technique. Also, in this technique, it can be seen bending of the guide wire or going to unwanted places. Long story short, what is the main difference between inside out and outside in? In inside out, you stand at the threshold of the door and look into the room. You don't step through the door. In outside in, you enter the room. Here the room is spinal canal and the door is medial edge of the pedicle. In outside in, you work very close to the nerve tissue. You have to be much more careful. Riskier, riskier. More effective, more effective.
En son bana da göster. Oh my God.
Bir kapatayım. Bir dakika. Ha, yani. Sonra aslında da gidelim.
Last but not least, I would like to say that we will be happy to see each of you in İzmir. Thank you.
Thank you very much, Professor Suju, for an excellent lecture. those interested in endoscopic techniques are just about to embark on this shore will benefit a lot from your insights and experience and sharing all the pitfalls and indications and contraindications. Thank you. It was an excellent lecture as always. Since I don't see questions in the chat, I will go ahead and ask the audience if they would like to comment or ask any questions. Maybe Dr. Celine, we can open the microphone for Bektaş Açıkgöz.
Thank you very much. Thank you, Professor Sucu, for this excellent lecture. Why it is excellent? Because you discussed the problems very briefly. Thank you very much. These are very important, I think, in the learning curve of our young colleagues who start endoscopic surgery. In microsurgery, especially for far lateral disc herniations, we use the same triangle like you, but we have to open much more space before doing that. But the procedure mostly is the same, but your advantage is going inside to the midline and taking out the midline disc herniations. Thank you very much. Congratulations.
Thank you so much.
Thank you, Professor. Dr. Selin Buzdağ, female neurosurgeon from Turkey, writes, I have no endoscopic experience, but thank you for the interesting presentation. And we have applause and standing ovations from Cumhur Kilincer in the chat. And I have a couple of questions before we see any questions in the chat. Professor Sucu, is there any difference, like in terms of in case of obese patients, which technique do you prefer? Inside out, outside in? Does it change your decision making process when the patient is obese? Or you had the case when there was a L5S1 fusion and the above levels were scoliotic. So in case of deformities, does it change like the way you draw your lines, or logically it should? So how do you manage in these situations?
Yeah, thank you very much. Actually, as I said, I just started to outside in technique, and first of all, I want to say that the inside-out technique, inside-out transforaminal discectomy, is the most basic, most minimally invasive procedure to learn first in spinal endoscopy. Again, you should only move on the outside in technique once you have learned the inside-out technique. And if there's no instability in the cases you talk about, and if the disc herniation is just on the disc level, is not migrated downward or upwards, and the foramen is big enough, is large enough, I may use the inside-out technique because it's simple and most minimally invasive technique. But if the foramen is narrow or the disc herniation down migrated, far migrated, I must choose the outside in technique. If the disc herniation L5S1 level, I cannot do with the inside-out technique. I must choose the outside-in technique. The outside-in technique naturally has an advantage for down-migrated disc herniations because the working cannula approach the disc level at an average of 30 degrees from cranial to caudal. So it has advantage. You can easily take out the down-migrated disc herniations with outside-in technique. Up-migrated disc herniations are difficult for both techniques. But generally speaking, if there is no spinal instability, if the spine is stable and you want to take out the disc herniation only, and there is no need for fusion, you must start the most minimally choose, then go step by step. And if there is a wide foramen, you can choose the inside out technique. But if the vertebral foramen is narrow, if the disc herniation is migrated, or if the disc herniation is calcified, you must choose the outside in technique. Let's say the inside out technique is the most minimally invasive, but you cannot solve all the problems. This may be 30%, 40% of the problems you cannot solve. The outside in technique is a little bit more invasive, but you can solve all the problems. It has potential. I don't say I am solving all the problems, but it has potential.
What about the central herniation? You mentioned that inside out would not be efficient. In this case, you choose outside in, right?
In inside out technique, you must start from a very low level, and we had difficulties in the beginning of the starting the transforaminal endoscopy. We had a complication, so we go up to spinous process level, and in midline disc herniations in inside out technique, you must go down for entry point, and you must go almost horizontal, and this is a risky procedure because you can enter the spinal canal and you can hit the nerve tissues, you can grab the nerve tissues. So I am afraid. But in outside in technique, you are going to the midline already with the working cannula, and you can easily take out the midline disc herniations. In inside out, you are stopping at the door. You are stopping at the foramen, and you are looking into the room. You are looking into the spinal canal. You are far from the midline. But outside in technique, you are going to the midline. So it has advantage.
Thank you very much, Professor, for a very, very good and precise answer. We have a few comments here from Sofiane. We have thank you for a very interesting presentation. Erkan wrote in Turkish, so I will try to translate. Professor, is there a high risk of dural injury in the outside in technique? And while the drill is advanced up to the spinous region, it seems to stop laterally at the epidural distance. Am I correct? I hope I'm translating it.
I don't know. I will try to answer. The antilles is made of a special design and never tear the dura mater. It never harms. We are touching the dura, and we are going to up to the midline. And 2 times I went from the posterior and I touched the dura, but it didn't happen any damage. The danger is you are standing very close to the dura. Sometimes you don't see the disc tissue, you only see the dura mater, and you must push the dura. It's yes, there is a danger in outside in technique, but in 11 procedures we had some technical difficulties, but all the patients had a good result. But it's too early to say something about recurrence and the other things. But if you don't Be careful. Yes, the outside in technique a little bit more dangerous, I think.
Thank you very much. Ahmed Baraka wrote, "Thank you for this excellent and very informative lecture." And from Harshad Perek, we have excellent lecture. Once again, I would like to ask in the audience if anyone wants to speak up and ask a question for. I see. I saw Dr. Jacob from Georgia. Is he still with us?
I don't know.
Maybe he has a question.
There is.
Thank you. Thank you. Thank you, Professor Hasan, for wonderful lecture. I don't have a question, but it was wonderful.
Thank you so much.
Thank you.
There is a question from Harshad Parekh.
Oh, how do you repair dural tear?
In the beginning of the inside-out technique, we had a nerve root injury, and we saw the leaves, but we didn't do anything. We pushed the nerves inside the dura, and we put a sponge, a little bit, little sponge, and the patient had a pain, neuropathic pain at the beginning, but it diminished for 1 month, and it didn't happen any both CSF leakage. In transforaminal endoscopic surgery, it is almost impossible to see CSF leakage because the entry incision is too small and the way is too long between the muscles and the subcutaneous tissues. There is no danger about the CSF leakage. But we didn't repair the dural tear because it was on the nerve root itself. It's almost impossible even in the open procedure.
Thank you. We have one more comment from Serpil Ulutaş. Thank you very much for this beautiful and informative presentation. İlkçu, İlkçu, yeah.
She is a chief nurse in our clinic.
Oh, okay. Thank you, Serpil, for your comment. Dr. Selin, would you like to add anything?
No endoscopic, spinal endoscopic experience, but thank you very much, Professor Sucu. It was interesting presentation for me. Thank you.
There is Sofyan Boli in the audience. He's from Tunisia. He came to İzmir to see the inside-out technique, and he learned in the course after you, Madonna. Maybe Sofyan want to say something about outside in.
Let's open their microphone. Sofian, would you like to comment or ask a question? Harshad Parek has another question, recurrent risk, but I think you mentioned that you 11 cases you still.
Yeah, in outside in technique, there is no recurrent risk yet because the time is too early, and about recurrent rates between two techniques, I cannot compare, but there is only one publication comparing the recurrence rates of inside and outside techniques. This publication states that the recurrence rates of inside-out technique are lower than outside-in technique. Yeah, and in inside-out technique we have some recurrent cases. I must say something about inside-out technique. We obtain the consent form from the patient by informing them that we will perform the surgery with local anesthesia and that you will be awake during the procedure, throughout the procedure. In the inside-out technique, first the disc is entered and the discectomy is performed. Even if we cannot remove the herniation directly, there is a possibility that the patient will benefit from the decrease in intradiscal pressure, especially in contained disc herniations. Percutaneous lumbar discectomy and laser discectomy are already performed this way. Therefore, in inside-out this transforaminal endoscopic discectomy, we have never converted to open surgery with general anesthesia in any of the surgeries. Indeed, we have observed that some of the cases that we were not satisfied with technically during the surgery benefited very well after the surgery. Of course, there were cases, recurrent cases, but I don't know the exact number at the moment.
Thank you very much, Professor. We have a comment from
Sufyan
Taxi.
here.
Yes,
from
Sufyan
Turkey.
wants to
He,
talk.
he was in our clinic for a course inside out. Maybe Selin.
I missed the name.
Sofyani, Bouali.
He turned on his camera right now.
Camera, yes. Mhm.
Yes. I sent request. Yes.
Yes, I want to thank you for this nice presentation. And it was a very nice experience when I passed many times with you in your department. It is a great experience for me. But I have a question, please, for inside outside. There is a difference for the L5 S1 level between men and women. How you can explain for us what you can do for this to reach this space, please?
Yeah, in the man, the iliac crest is higher than the women. So in the women, L5 S1 discectomy, transforaminal discectomy is easier. We performed 2 L5 S1 discectomies by now. Both of them were women. I haven't performed any L5 S1 discectomy in men yet. So I have no experience, but if I have a patient, I will try.
Thank you. Thank you very much.
Thank you so much.
Thank you. And from Taksin, İzmir Katip Çelebi University Neurosurgery Department, thank you for an informative presentation, Professor, with the brain emoji. I guess there are no more questions in the audience or in the chat, so all is left for me to thank you once again, to express my gratitude for such an educational lecture. And also, I think it's inspiring for the young neurosurgeons who are willing to start this new technique and expand their surgical horizons. So thank you, Professor Sucu, for being inspiring role model for us and for providing the platform, not just online, but offline at İzmir for training new generations of neurosurgeons. Thank you once again.
Right. Okay. Selin, you are the one who will close the session.
I'm closing this section. Thank you, everyone. Good night.
Bye.
Thank you.